Okay. Good morning, everyone. We are now live. Welcome to our 100th session of teleshadowing. We're live on YouTube as well. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Mubasher. Dr. Adnan Mubasher is a practicing pathologist in Clovis, California. He completed his training in anatomical and clinical pathology, followed by a fellowship in dermatopathology from the Icahn School of Medicine at Mount Sinai Hospital in New York. He served as the chief resident during his training and is currently the treasurer and member of the executive committee of the Pakistani American Pathologist Society. And now it is my honor to request Dr. Mubasher to begin today's session. Thank you.
Thank you so much, Manahal. Can you guys see my screen?
Yes.
Perfect. So thank you for the kind introduction. I just recently finished training and I joined the job last year. So I'll talk a little bit about the field of pathology because most of the medical students here or abroad, they're not really exposed to the day-to-day working of pathology and have very little to no idea about how pathology works and what are the challenges and what are the pros and cons of this field. And I'll try to touch a little bit on that before I dive into the pathology part of the lecture. So pathology is it's a really diverse field. And as you can see from these subspecialties that I've listed on the screen, I might be missing a few, but when you start a pathology residency, most of the programs in the country are anatomic and clinical pathology combined programs. They're usually 4-year programs. You do 2 years of anatomic, 2 years of clinical pathology, plus minus few months here and there. And you go through all these anatomic pathology rotations where you're exposed to literally all the organ system of the body. And then you go towards the clinical side and you have the transfusion medicine, chemistry, microbiology, molecular pathology, and clinical informatics. And all in all, you learn, the learning curve is really steep. You learn a lot during training. And then on top of that, during your training, when you develop your interest in something specific or specific organ system, then you spend another year or two just training in the intricacies of that organ. And this is one of the best parts about pathology to me, is that it's so diverse. You don't have to choose right now what you want to do, as long as you know at least have a broad sketch of what you want to do. And then you can always narrow it down when you start your training. And then you go through these rotations, and then there are a lot of factors that go into it. Organ system, your teachers, and the environment you're trained in. A lot of things influence your decisions on what you actually want to end up doing. So again, this is from the match data this year, from 2023. This is the NRMP's data, and it breaks down all the subspecialties and the number of people applied versus number of positions offered, and the number of people who match, a little bit about their background as well. And yes, you have to be a physician to apply for pathology. You cannot be a pathologist without being a physician. And there are different routes you can take. You can go to medical school here in an MD program or a DO program, or you can be a physician from abroad and you have to go through all the USMLE exams. And then once you have cleared all the requirements, then you apply for residency. So I'll just focus here on the pathology part. Roughly 600 or something positions are offered, of which this year, and I've been seeing the same kind of data in the past few years, you have very few number of empty spots that go unfilled. And then you have a mix of US grads, US DOs, and international medical graduates, including myself. I graduated from medical school in Pakistan. So it's a good mix and match specialty. When you train with people, you have all sorts of backgrounds, which is really good for you to grow as a person and as a physician. And I get asked a lot about the job market of pathology, and people are scared that, oh, you might not get a job or this or that. There's so many misconceptions about this. This is the data taken from the pathology outlines. It's a really good educational resource, as well as they also advertise jobs across the country and abroad as well. So this is just the data for the past 4 or 5 years, and it shows the number of jobs that are available at this point in time. And mind you, there are like 500 to 600 graduates every year, so it's more jobs than the number of people graduating. So the job market is pretty good right now. So that's another fear that I commonly students ask me about this, and you don't have to worry about that at all. Especially since I've gone through the process recently, it's a pretty good job market. So why is it an exciting time to be a pathologist right now, or especially in pathology training? Because the field is really growing at an enormous pace right now. There's so many new things that are coming in. Pathologists generally are thought of somebody who would sit at the scope and just look at the slides or just do autopsies, and that will be the end of it. But you don't see the exciting part, which is all these digital pathology, the AI, machine learning, and then the personalized medicine. Now, I will touch briefly on each one of them. Each one of them is a separate lecture, basically. You can talk for hours on each one of the aspects of pathology. But diversity, I already talked about the different aspects and the different organ systems that you go into. But for example, digital pathology, this is not from a future pathologist. This is actually what's happening right now in practice. On the right side is, let me just minimize this. Is Dr. Parwani in Ohio State, and they've been using this for primary diagnosis for the past few years. And I know, including Mount Sinai and a lot of other institutes that use at least part of their services, use digital pathology as part of their sign out. You don't even see the scope on the desk. You see multiple screens, and just like radiology, you have all the images that are scanned into the system, and you interpret the images, and then it gives you the gross images, the histological images, and any of the stains that you might have on the case to view on your on the multiple screens that you have. And then the same on the bottom left side. This has been used for all the conferences, tumor boards, and honestly to reach out for medical education. So digital pathology is already there where it's being used as a tool for primary diagnoses. So when we say digital pathology, the images obviously don't just pop up. There's a whole background to it, and how basically a digital image is created. We'll start from the gloss slide. Even the gloss slide part, you get to the gloss slide part, there's a whole process in the back. You receive the specimen, biopsy or excision or cytology slides. So you make this gloss slide, and then once the tissue is prepared, those slides are then scanned using a whole slide digital imaging whole slide scanner, and this will create a virtual slide. And then that virtual slide is stored in a database, and then through that database is using different softwares. You can view those slide images, and then once you view those slide images, you diagnose based off of your of the data that is provided. If you have to do multiple additional studies, like ancillary studies, including immunohistochemistry, you perform those, and then you put that data together into a report format, and then you upload it in the LIS, and that is how the final pathology report is generated. This is a simplified version of how digital pathology works. This is another, this is a really good platform I developed by one of my mentors, Dr. Singh. This is just one of the many platforms that are out there that are already scanning the slides. They're also very good for the medical students and the college students. If you're interested in pathology, there are free resources at their website as well, where you can go and see the whole slide images that are already scanned at their website. Talking about when somebody says artificial intelligence or machine learning in pathology, it's such a huge field, and we can go on and talk about it for an hour. But basically, the gist of the matter is that once you create a slide, the digital slide is created, and then that digital slide is, as opposed to being read by a pathologist, if you train a machine to read the patterns on that histology image. That's what basically artificial intelligence and machine learning is. There are so many different ways to do it. There are so many big companies that are already using all that data and trying to come up with algorithms that they can use to interpret those slides. Now, these are just the tip of the iceberg. There are so many more new startups that are doing the same thing. So basically, on the right-hand side of the image, you can see this is the whole slide image. And once that image is annotated, all these blue circles, they highlight the entity of interest. If you're looking for a carcinoma, or if the software is trying to look for pleomorphism meaning the difference in the size of the nuclei. So these things are annotated, and then machine highlights it and then kind of gives you a percentage or an logarithm where they basically put the data together and come up with an answer. For example, on this side, you have high-risk cells as opposed to low-risk cells, and then that data is used to generate the final report and also used for prognostic purposes. A lot of the machine learning part is still in the research, but there are aspects that are being used on the clinical side. For example, to interpret prostate biopsies or breast biopsies, there are some FDA-approved softwares that you can use to quantify or also to highlight the areas of interest. The next question that kind of automatically comes to your mind that, oh, if the machine learning is doing all of that, then what's the role of a pathologist? Basically, machine learning is not at that point where it can basically replace a pathologist. And if you ask me personally, again, that's a whole different debate. But if you ask me personally, I don't think it will ever replace pathologist. It will be a tool that will be used by the pathologist to provide a more personalized and more efficient care. And it will not be something that will be replacing the pathologist, just like what's happening in other fields of medicine, radiology or internal medicine. The artificial intelligence is being used as part of something that is assisting the physician as opposed to replacing the physician. And I think the same is going to happen with artificial intelligence and machine learning. It will be used, for example, to count mitoses or to count blast cells or to highlight, for example, in breast pathology or prostate pathology, highlight the suspicious areas that might contain cancerous cells. But then it will eventually be at the end, it will be the pathologist will be looking at those cells and putting the data together to come up with the final report. And then one last thing before I move on to the pathology part of lecture is the precision medicine. Basically, it used to be that the more tissue you have, the better it is for pathology. The more cells you can look at, the more data you have to interpret. And now we're moving towards an era where there's less and less amount of tissue that is being taken out. For example, you have more FNA core biopsies that you're doing, where it's a very minimum invasive procedure that is giving you very scant amount of tissue, and then that tissue is being run through molecular testing to come up with the genetic profile or the genetic profile of the tumor, basically, and then those targeted therapies that are targeted towards that particular tumor are being introduced, and they're being implemented in thyroid pathology, in melanomas, and in a lot of other subspecialties. So I think all of this together, it's a very exciting time because the field is evolving. When something evolves, it's good to be part of the change, and you learn a lot during the process. And I think that's what's happening with pathology right now. It's evolving. You're coming up with so many new and exciting things. And it's not just interpreting the slide. You can, if you're good in technology, if you're good in genetics, all of those things are adding up. And you have all these toys to play with. So, which for me personally is a very exciting part of pathology. And I would highly encourage you guys to explore that site, especially the medical students, before you make up your mind on what you want to do for the rest of your life. And lastly, I think the pathologists play a huge role in personalized medicine. When I say personalized medicine, it's basically one size fits all approach doesn't work. Yes, you have one person's carcinoma, even let's say colorectal carcinoma or a melanoma. Especially, let's talk about melanoma. One person's melanoma might be totally different in genetics from the other person's melanoma. So now, because of this personalized medicine, where you can do all the genetic testing and molecular testing on those neoplastic lesions, you come up with the specific abnormality that is driving that tumor entity, and then you can target that antigen or that genetic on the genetic level, and then you can cure that part. So pathology plays a huge role in the personalized medicine because we're the ones who are diagnosing and then giving all that data for the clinicians to basically make their treatment plans based off of. All right, let's move on to the pathology part of things. So I'm going to talk about skin pathology and the general patterns that you see in a skin biopsy or in a skin disease. So before I go into the pathology of skin, let's talk about the normal histology of skin. So in the normal histology, you see, so this is the normal histology, that different parts of the skin are highlighted. The first starting from the top, and you always have to have an logarithm look at either start from the top, go down all the way to the dermis, or start from the dermis, go all the way up to the top. Most of the people, when they look at any slide to interpret, they have a logarithm in their mind, and that's what you get in your training. That you always start from the top. For example, when it comes to skin, you start from the top. You look at the stratum corneum, which is this basically dead keratinocytes. It's like a basket weave pattern, and then you look at the stratum corneum, you see if there's any abnormality there, and then you move down all the way to the deeper parts of the dermis. So stratum corneum, and then the epidermis has stratum granulosum, which is this darker layer of skin, and then you have stratum spinosum, which is underneath stratum granulosum, and then you have the stratum basal, which is the basal layer of the epidermis. And then right underneath the basal layer, all this light pinkish area that starts, that is part of the dermis. And then all these dermal projections that seem like they're going into the epidermis and have those small vessels, they're called dermal papilla. And then dermis has two parts. Only one part is evident in this picture. You have the superficial part, which is the papillary dermis, and then you have the deeper part, which is called the reticular dermis. And then below the reticular dermis is the subcutaneous fat, you call it subcutis. So that is the normal histology of skin. Now let's talk about some of the general patterns. So with derm path, it is mainly divided into neoplastic and inflammatory derm. We're going to talk about some of the patterns that we see in inflammatory derm as opposed to neoplastic. So in the inflammatory side of things, again, we're going to talk about patterns. Once you recognize a pattern, you can narrow it down to the differential diagnosis. And then there's smaller hints of, then you can further narrow it down based off of other histological hints that you see in the slide. So pattern that involves epidermis and dermal epidermal junction. These are the four basic patterns that will involve the epidermis and dermal epidermal junction. Spongiotic reaction pattern, sericiform reaction pattern, interface dermatitis, and then vesiculobullous reaction pattern. We'll briefly talk about all of them before we go into the differential diagnosis. So when somebody says spongiotic reaction pattern or eczematous reaction pattern, you see this is the high power image of epidermis. And what's wrong with this epidermis is you see all these empty spaces between the keratinocytes. They're basically fluid that is pushing the cells apart. And then when the fluid becomes thick, it just starts to become a vesicle. and that is called spongiosis. It's basically the fluid that is seeping into the epidermis and giving this spongiotic look. When somebody says spongiotic, that's what it means, fluid in the skin, the top layer of skin, epidermis. And then in the background, you see all these blue dots that are seeping into the epidermis. These blue dots are lymphocytes that are extravasating from the underlying dermis into the epidermis. This process is called exocytosis. So when we put the slide on the scope and we see this image where there's a lot of fluid in the epidermis and fluid is pushing the keratinocytes apart, and they're in the background, you have this extravasated lymphocytes. So that tells you that we're in the spongiotic reaction pattern, as opposed to this pattern, which is called psoriform reaction pattern of epidermis, where you will see hypertrophy of the epidermis. And then hypertrophy of the epidermis is also called acanthosis. So you have these stretched out reti ridges, and then you have suprapapillary plate is thinned. You have these dermis that is going into the epidermis and kind of stretching out the suprapapillary part of the dermis. So this reaction pattern is called psoriform reaction pattern. And moving on to the next, we'll talk more in detail about these patterns once I cover the basic patterns, and we'll talk about the differentials that we will see in those patterns. The next reaction pattern of those four is interface dermatitis. So interface reaction pattern has two sub-patterns. One is lichenoid reaction pattern, and one is vacuolar interface dermatitis. In the lichenoid, the one you see on the left side of the image is, you see this dense lymphocytic inflammation that is hugging the dermal epidermal junction, and kind of obscuring the demarcation of epidermis into with the dermis. So that pattern. Even on low power, you see this is part of the lichenoid reaction pattern, as opposed to vacuolar interface dermatitis. You still have some of these blue dots. These blue dots are all lymphocytes. So you still have some lymphocytes that are hugging the dermal epidermal junction, but the main pathology here is these small holes along the dermal epidermal junction, and hence the name vacuolar interface dermatitis. And this interface is basically the junction between epidermis and dermis. So you have vacuoles at the dermal epidermal junction, and hence the name vacuolar interface dermatitis. And the last of those four reaction pattern for epidermal and dermal epidermal junction is vesiculobullous disorders. And you have the split. So basically a bulla is being formed, and then depending on where the bulla is forming, you subcategorize it either in intraepidermal, within the epidermis, or subepidermal, which is below the epidermis and above the dermis. That will be subepidermal split as opposed to intraepidermal split. And based off of where the split is, your differential diagnosis will be different. That was those four patterns for epidermis and dermal epidermal junction. Now moving on to the dermis, you have these five patterns that you see in the dermis. Superficial perivascular, superficial and deep perivascular, granulomatous pattern, fibrosing pattern, and paniculitis. So superficial perivascular pattern will be, you have these superficial vessels in the papillary dermis, and then you will see these blue dots kind of hugging those vessels and just staying on top of the dermis, as opposed to coming down. So in low power, you will see superficial will just stay on the superficial side, and deep will have deeper vessels encircled as well. Why is that important, superficial as opposed to deep? There, on superficial side, you'll have dermal hypersensitivity reaction type of things, or urticarial reactions. There's a total differential diagnosis on the when the inflammation is limited to the superficial vessels, as opposed to if you have superficial and deep, that differential diagnosis changes. Granulomatous reaction pattern. So granulomas in general in pathology are, you see multinucleated giant cells, you see histiocytes, you see a lot of inflammation. But when it comes to skin, even just collection of histiocytes would technically count as a granulomatous reaction. And histiocytes are these faintly pink with the blue dots. These are histiocytes. Then they're kind of encircling an area, forming like a granuloma. So that is what the granulomatous reaction pattern would look like in the dermis. Fibrosing or sclerosing disorders. Even on low power, you will see that the whole dermis is kind of sclerosed. You will not see much in terms of subcuticle fat or adipose tissue, and then there will be loss of adnexal tissue. And you will see maybe some follicle remnants are here, but then there's a loss of adipose tissue that encircles the follicle unit. And paniculitis will be much deeper in the dermis. It is a disease of the subcutis, disease pattern of the subcutis. And you will see in the subcutis, either you will have septal paniculitis. These are the septa that are thickened, as opposed to normal septa should be like 1/4 the thickness of the septa. And you should not see these many lymphocytes in the septa. So you have paniculitis, which can be two types, septal versus lobular paniculitis. We'll talk more about it down the road. And then you have loss pattern would be essentially normal skin pattern. On initial screening, you will see skin which looks more or less normal, and there's no overt pathology on low power that you can see, but that's also in the there's a whole differential list for normal skin histology. You can have urticarial reactions, mastocytosis, you can have in this dermal elastosis, you can have some of the infections. So that's also a pattern of disease. So let's talk more about the specific patterns now. So going back to the spongiotic reaction pattern. So in spongiotic reaction pattern, we'll have this is somebody who presented with these itchy bullas on the skin, and there's a diffuse rash in the background. And then there's a dry rash versus this is like more wet. You see the liquid coming out of those bulla. So even on just the examination, we know if we take a skin biopsy of this lesion, it will translate into, this is all the fluid that is being collected in the skin, in the epidermis. And as we talked in the spongiotic reaction pattern, you see all this fluid is stretching the epidermis and pushing the keratinocytes apart. And then in the background, you have these sprinkling of lymphocytes that are coming from deeper in the dermis and into the epidermis. And the process is called exocytosis. You might see another name in the books, epidermotropism. It's the same kind of process, but in that disease, differential is totally different. You see epidermotropism in something that in mycosis fungoides, and then same thing, lymphocytes moving into the epidermis, you call it exocytosis when the changes are spongiotic. And in the background, you see all these pink dots. There are eosinophils in the background, which goes along again with the spongiotic reaction pattern. You can see it in, again, a number of diseases, including eczema, nummular eczema, contact dermatitis, all those things that affect the superficial dermis. So it's basically a clinical pathological correlation. It's not, you can't take clinical separately and the skin histology separately. It's a combination of the two. You see on the clinical side, you see this, and then you want to make sure as a clinician that you're in the right category, or if we can, and you have a differential, clinical differential, and to rule in or rule out certain things, you do the biopsy, and then in this we can say for sure that it's a spongiotic reaction pattern as opposed to any of the other reaction patterns. Going on, so when spongiosis becomes more chronic, that lesion was more acute. When it starts to become subacute, you start to lose some of the some of the fluid in the epidermis. You still have pockets where you see the fluid, but for the most part, the fluid's gone. The epidermis is becoming more hypertrophic, and there's some inflammation that still stays in the background, and you have exocytosis. So that happens when the lesion starts to become more chronic. There's weeks into the process. It's not as acute, like it's not 1 or 2 days of onset. Now it's becoming more weeks of onset, and there might be some corticosteroid that is applied on top of the skin. So you may see this is also spongiotic reaction pattern, but the spongiosis is less pronounced. So the lesion has moved on from acute to a subacute phase. Or in this case, the lesion has gone completely from acute phase to a chronic phase. So it totally depends on when you take the biopsy of what you will see in the histology. But it will still be a spongiotic dermatitis. I don't have high power on this, but you will still, there was some spongiosis over here. Spongiosis again means the edema, the fluid in the epidermis. And then once you have that histology, what are our differential diagnoses? As I said, once you recognize the pattern, you narrow it down to a few differentials, and then you take the soft clues and then the other histological criteria to call it one thing or the other. Most of the times, spongiotic processes are hard to delineate, but if you see eosinophils, your differential diagnosis will be limited to a few entities, including allergic contact dermatitis, eczema, or partially treated psoriasis even can sometimes come up with eos and spongiotic reaction, or arthropod reaction. Or if you don't have eosinophils, but you have spongiosis, it can narrow it down to irritant contact dermatitis, nummular dermatitis, or AID reaction. Obviously, having said that, a lot of overlap exists between different spongiotic entities. And then also we do PAS stain to see if there are any fungal infections. Let me just go show you. And this is what a fungal infection will look like on the skin. Usually these fungal hyphae are not, on a routinely basis, are not evident on histology slides. You can look for them harder, and you may find in the cases when there's a lot of hyphae. But usually spongiotic reactions, we do PAS or GMS to see if there's hyphae in the sternum corneum. That can also give the same changes that we saw in the eczematous process. So clinical is very important, and based off of clinical, then you take the clinical data, and then you take what you have in histology, and you put 2 and 2 together and try to come up with a narrow list of differential diagnoses so that the patient can be treated with more confidence and for the right thing. Right. This is again same pattern, spongiotic reaction pattern. You see a lot of edema fluid in the epidermis that is forming into a small bulla, and then you have these lymphocytes, these small dots that are percolating in. If it happens in the acral surfaces, then it's called dyshydrotic eczema. You can have the same histology, irritant contact dermatitis. There is something that is irritating the skin from the outside. You will have the spongiotic changes in the epidermis, but then you will have something like this that looks like an external injury to the skin. But a lot of the times, you put that differential diagnosis in the report and let the dermatologist or the clinician decide, because they, well, if they provide you the history, then you can sometimes narrow it down, or if they provide you a clinical picture along with the history, then it's even better. The more data you have, the more precise diagnosis you can give. But if you just say spongiotic dermatitis and this is the differential diagnosis, I think 90-95% of the job of a derm path is done, because you've ruled out all the other entities and you've narrowed the differential down to 2 or 3, 4 entities. This is another entity that shows spongiosis, the Stacey's dermatitis. You will see subtle spongiosis in the epidermis, but the main things that you see in Stacey's is you will have proliferation of these smaller vessels in the papillary dermis. Usually happens on the lower legs because of the anatomical side. The vessels are have more pressure on them, and the blood can stay there longer and causing stasis dermatitis. Moving to the second reaction pattern, psoriasiform reaction pattern. So in the clinic, well, usually this kind of lesion is not biopsied because it's clinically very evident that what you have there is, scaly, well-demarcated plaques, which goes along with psoriasis. This is a typical picture that you will see in psoriasis. But if it's being treated and it's not responding to the treatment, or if the clinician is not sure with the history and they want to rule out other entities, they do the biopsy of this lesion. And what you will see under the scope is on the right-hand side, you will see the psoriasiform reaction pattern, even on low power. When I say psoriasiform reaction pattern, I mean these extended reti ridges, bulbous reti ridges. When I say bulbous, that means you have these extended reti, and then you have kind of thickening of the bulb. So you have bulbous reti ridges, and then they're all regular. There's regular versus irregular bulbar expansion, but without going into detail on that, you will see hypertrophy of the epidermis. You will see parakeratosis on the top, and you can correlate that with the clinical side. On clinically, you see that scale on top of the lesion, and that scale is evident as parakeratosis over here. And then within the parakeratosis, you will see neutrophils. And then because of this elongation of reti ridges into the dermis, you will have the papillary vessels that will be kind of not entrapped, but kind of going into the epidermis, making the suprapapillary plate thin. So you will have thinner areas of skin and you will have thick areas of skin. And then on top, you have this plaque of parakeratosis, and within the parakeratosis, you will see neutrophils. That is the classic histological and clinical picture of psoriasis. And this is the high magnification image of the same thing that I was talking about. You have expansion of the epidermis, hyperkeratosis, and then you have kind of the papillary dermis that is going inside the epidermis because of the expansion of parakeratosis, expansion of the epidermis. And if you compare this with the normal histology that we saw at the start of the lecture, you will not be able to find a granular layer in the epidermis. So when there is a fast transfer, fast turnaround time of the epidermal cells, that granular layer is kind of pushed out because the cells are mitotically active, they're pushing upwards, and this is what the parakeratosis is. Basically dead keratinocytes that are retaining the nuclei and don't have enough time to shut that nuclei off and turn into normal stratum corneum. So you will see loss of granular layer, suprapapillary thinning, extension of reti ridges, and you will always see some neutrophils in the stratum corneum. There's some here, there's some here. And 2% of the US population has psoriasis. So any pathologist who's training right now, or any pathologist who's practicing, should be well versed in the diagnosis of psoriasis, because the treatment will depend on it. That was one variant of psoriasis. Now we have other two variants, guttate psoriasis and pustular psoriasis. The one we just saw was classic plaque type psoriasis. Well, guttate psoriasis, you will have a much younger patient population that will come up with these droplets of petal-like lesions. And they will appear suddenly, and they will not have a diagnosis of psoriasis. Even on these lesions, if you look closely, you may find some scale and well-demarcated lesions. And in the histology will be slightly different as opposed to the classic type. You can see there's bulbar extension, but it's not as psoriasiform as you hope. The things that you will always see are parakeratosis and neutrophils. So, and areas like this, you will have loss of granular layer. So putting 2 and 2 together again, younger population, a clinical lesion that looks like this, and then a histology that correlates with that clinical lesion and have neutrophils in the parakeratosis, then you can more confidently say that it's a guttate form of psoriasis. This is another form of psoriasis where it will appear suddenly. Patient may have plaque psoriasis in the background, develop these plaques and papules on top of those. And on histology, that will correlate with the clinical image that I just showed you, will show these huge neutrophilic abscesses that are forming within the stratum corneum on the top layer of skin, but they're pushing the epidermis down. In addition to other features of psoriasis, loss of granular layer, parakeratosis, and psoriasiform hyperplasia of the epidermis. So depending on the type of the, depending on the variant of the disease, and also depending on the chronicity of the disease, you can see different histologies. But if you see enough of these, and that's what you do in your training anyways, you see a lot of cases, you see a lot of different variants, you'll see lesions at different stages of the disease, and you recognize the pattern on the low power, and that really helps you narrow down these differential diagnoses. And having said that, that was psoriasis is a prototype of psoriasiform reaction pattern. All these entities, and this is a very short list of entities, these entities can also show similar histology to psoriasis. The difference literally would be that you have to know the clinical, what the clinician is seeing and what the history is provided, and then you put the histological picture and suggest one of these entities. Moving on to the lichenoid reaction pattern. So this is a prototype example of lichen planus. You will see these plaques and papules that will be very itchy. You can see them in the wrist area or in the ankles, and the patient will be itching them really hard. And on histology, you will see this pattern, lichenoid reaction pattern. And as we talked before, lichenoid reaction pattern has two patterns, interface dermatitis and lichenoid inflammation. So in lichen planus, you will see something like this. You will see all this sea of blue that is hugging the dermal epidermal junction. So sea of blue has all these lymphocytes, all these small dots are all lymphocytes that are kind of just going along the dermal epidermal junction. And in the epidermis, you will start to see these pink globules. These are basically dead keratinocytes. There are so many different names in the books for that, Savat bodies, apoptotic cells. All of these are part of the reaction pattern. Some of the cells, keratinocytes, are dying. And then because of the damage to the dermal epidermal junction, you will, it's not as evident in this image, but you will see some pigment drop out in the papillary dermis because the pigment is contained in the basal layer too. And once it is damaged, it's kind of dropped out in the papillary dermis. So you see this histology and you see this on the clinical side, and you put two and two together, and then that will be consistent with lichen planus. That is just one entity. There are other entities that can show lichenoid inflammation or vacuolar interface dermatitis. I mean, benign lichenoid keratosis can show the similar histology, but you will have, as opposed to a rash, you will have a single lesion. Lichenoid drug eruption will literally show you the same histology, but will likely have eosinophils because the drug eruptions usually have eosinophils, not always, but likely. And then lichen nidus, lichen sclerosus. This is an example of lichen drug eruption. You still see the same thing, lichenoid reaction pattern. You see all this sea of blue that is making the dermal epidermal junction hazy. And if you go on higher power, you will start to see in that sea of blue, there will be pink dots, all these pink cells. These are eosinophils. So when you start to see eosinophils, then you start thinking about reactions that are related to drugs. This is another entity with the lichenoid inflammation, lichen sclerosis. Here, the only difference is you have sclerotic papillary dermis. And basically, this inflammation started at the top, at the dermal epidermal junction. And then slowly over time, that inflammation is pushed down, and then the papillary dermis becomes more sclerosed, and hence the name lichen sclerosis. So that was lichenoid pattern of interface dermatitis. Now we have vacuolar interface dermatitis. On the clinical side, you will see somebody come up with these targetoid lesions on the palms, and will have mucosal lesions either in the oral mucosa or in the other mucosal sites. They may have a history of NSAIDs intake or other drugs. NSAIDs are the most common. You can also have some infectious etiologies. And when you biopsy these lesions, you will see this interface change. As you can compare with the previous slides, the inflammation, the sea of blue is not as dense. You see still blue dots in the upper part of the dermis, and they're more sprinkled as opposed to just completely washing out the papillary dermis. And then, let me see if I have a higher power. Yeah. And then if you go on a higher power, you see these small vacuoles at the dermal epidermal junction. So this is vacuolar interface dermatitis. And also in the epidermis, you will see this keratinocyte, these pink globules, the same thing that we saw in lichenoid dermatitis, like here. Just compare that there's so many more lymphocytes as opposed to here you have still that interface change. You have the lichenoid inflammation, but you have more vacuoles than you have those lymphocytes. And then there are dyskeratotic cells. If you have this histological presentation and you put it together with the clinical, that will be more suggestive of something in the lines of erythema multiforme. Some books call this vacuolar change as moth-eaten appearance. You will see all these names that are analogies with different things. But it's basically, you visualize these things and it's all comparing pictures. But having, so coming back to the case, erythema multiforme will be in the differential. You can also have graft versus host disease. You can also have fixed drug eruption. They all can show similar changes. And that's why the clinical is very important in inflammatory derm path. You compare the clinical presentation and you compare the histology, and then you arrive at a more particular diagnosis. Similar process, you have death and dying going on in the epidermis. You have these pink globules that are dead keratinocytes. If they just completely, the whole epidermis starts to become completely dead, then that goes into the TEN category. It's the severe form of erythema multiforme. It's the, and also it depends on the clinical, how much the body surface area is involved, 30% versus more diffuse. And there's more clinical consideration that goes into making this diagnosis. But on histology, you will see a much more necrotic epidermis. Again, coming back to the basics, you recognize the pattern, then you narrow it down to different differential diagnoses, and then you compare it with the clinical to come up with a diagnosis. For example, if the patient has a history of a graft placement, or and then you see those changes, then it will be more GVHD as opposed to just EM. Or if the clinical history suggests more of a fixed drug eruption where a lesion keeps coming back after the patient starts a certain drug at the same site, then similar histological changes will make the diagnosis of fixed drug eruption as opposed to other diagnoses. And similarly, on the other end, if you see vacuolar interface change, and then the patient has a history of connective tissue disorders, or doesn't have any necrotic keratinocytes, and there's inflammation in the superficial and deep dermis as well, then you go favor more towards the connective tissue disorders. Same thing, lichenoid inflammation. trying to go faster so that I can go through more entities. Again, same thing. You have vacuolar interface change, and then, but along with that, you have this superficial and deep perivascular and periadnexal inflammation, and that goes more with connective tissue disorders like lupus and with dermatomyositis too, but the inflammation will be much less. Then vesiculobullous disorders. This is one of the last patterns in dermal epidermis, in the disease of the epidermis. So depending on where the split is, if the split is within the epidermis, subcorneal, you will have staphylococcal scalded skin syndrome, you can have pemphigus foliaceus, you can have bullous impetigo, or if it is suprabasal, like it's still in the epidermis, but where in the epidermis it is, will be pemphigus vulgaris. Let me just show you a few examples. So there's a split within the epidermis, and it's subcorneal, and it's full of all these inflammatory cells. That's a picture you will see in bullous impetigo. And then pemphigus foliaceus, you will still see the split within the epidermis, but not as superficial, slightly more deeper in the epidermis. And then staphylococcal scalded skin syndrome, you'll have a much superficial split and with very less inflammation. So the bottom line is, once you recognize there is a split within the epidermis, so the diagnosis will be intraepidermal split, and then all these differentials come into play. And then you compare that with the clinical, and there are other testing that you have to done, like direct immunofluorescence or indirect immunofluorescence, to actually arrive at the diagnosis. But histologically, these are your clues to narrow down the diagnosis. Now, again, the split is still in the epidermis, but it is much deeper within the epidermis, close to the basal layer. And as you see, most of the epidermis is kind of gone. So those were intraepidermal splits. As opposed to that, you have subepidermal split. Now the split is between epidermis and dermis. There is clinically a bulla, but now it's deeper than the other entities. It's below the epidermis. And then again, the differential diagnosis based off of where the split is will be totally different. It will be bullous pemphigoid versus porphyria cutanea tarda. And then depending on what inflammatory cells are present within that bulla, your differential will go one way or the other. For example, if you have eosinophils, predominantly eosinophils in that cleft, then it's more in line with bullous pemphigoid, bullous drug eruption, bullous arthropod bite, bullous wells, herpes gestationalis. All these will be in the differential, and then you will compare patient's history, patient's clinical presentation, and then you'll put 2 and 2 together and give out the data in your final report. Similarly, if you have more predominantly neutrophilic split, then these are the different kinds of entities that can have that histology. Perivascular dermatitis, this is the superficial and deep. So let's say if we draw an imaginary line here, somewhere around here. If you see inflammation on top, this is the papillary dermis. If you see inflammation on the top of the dermis, that pattern will be superficial perivascular dermatitis. And if you see dermis diffusely in the superficial and deeper vessels, you see inflammation around all of the vessels, then that's a totally different pattern, and the differential diagnosis will be different. What's a clue to tell that if it's a perivascular as opposed to just diffuse inflammation? In perivascular inflammation, you will have these islands of blue. And if you go on higher power, which I didn't go here, but if you go on higher power, you can see there are vessels at these locations, and hence the lymphocytes are kind of aggregating around those vessels. So in a diffuse inflammation, you will have a complete washout of the dermis with those inflammatory cells. That's how you differentiate from differentiate perivascular from the interstitial inflammation. And then you ask the next question, what is present in that infiltrate? Are there all lymphocytes, eosinophils, neutrophils, plasma cells? What are those cells? And then depending on what cells you find in that inflammation, again, you will come down to a small subset of differential diagnosis. This is an example of a more diffuse process. As you see, there's a complete washout of the dermis with the inflammatory cells, and the higher power shows that most of those inflammatory cells are neutrophils, so which goes along with the Sweet syndrome. And then you compare the clinical, and then that will be the diagnosis. Alrighty, so moving along faster. Coming to granulomatous inflammation, there are 3-4 types of granulomatous inflammation that you need to know if you're differentiating what sort of granulomas are there. These are palisaded granulomas. Palisaded means that the granuloma has a fence around the central part, and you see that there's kind of like they're fencing off this area, they're fencing off this area. So that is what the palisaded granuloma means. So you will see that in granuloma annulari. You have the central pinkish area that is being fenced off by these histiocytes. And then the other differential diagnosis will be necrobiosis like lipoidica, rheumatoid nodule, necrobiotic xanthogranuloma, but those will have different types of granulomas. This is an example of a rheumatoid nodule. You will still see the central pink stuff, which is being cordoned off by these histiocytes, but it's much deeper in the dermis. Patient may have history of rheumatic disease. Then you have sarcoidal granulomas. They again have a specific morphology. They look very multinucleated giant cells, and they look very compact. They're very different looking than the palisaded granulomatous inflammation. And then lastly, you have foreign body giant cell granulomas. You can see that there are so many clefts, and those clefts mostly contain keratin. You mostly see this kind of picture in a foreign body that is lodged in the skin, or if you have a skin cyst that the patient tried to take off themselves, or try to punch on it, or try to do any other sorts of maneuvers with it, and it kind of ruptures within the skin, and the keratin that is contained within the cyst causes this granulomatous reaction in the surrounding skin. Fibrosing disorders. In the fibrosing disorders, on the right side, you see that there's the biopsy usually shrinks after the skin is taken out from the patient, but in sclerosing or fibrosing disorders, they kind of, because the skin is so thickened, it kind of stays the same. It's like there's no loss, there's no thinning at the bottom, and then you will see loss of periadnexal fat. There's hardly any space in between these collagen bundles, and then you have the rectangular shape of the body, and that pretty much sums up. And then you have the remnants of adnexa, but there's no adipose tissue around it. So that is a sign for sclerosing, fibrosing disorders. Obviously, before diagnosing anything with sclerosing, fibrosing disorders, I compared with the clinical, and also there are other signs, like you look for plasma cells in the scant inflammation that you do see. And one of the last patterns is paniculitis. Erythema nodosum is considered the prototype of septal paniculitis, and you will see acute and chronic inflammation in the septum. So basically, as you can see, there will be a totally different type of skin biopsy that will be required to make that diagnosis. Some of the common skin biopsies are shave biopsies or punch biopsy. And then you have the excisional biopsies, where you take a bigger chunk of the tissue. Superficial biopsies, if the process is confined to the skin, and that's what your differential diagnosis as a dermatologist is, you will do a superficial shave biopsy. But if you're considering, for example, paniculitis, you will need to do a deeper punch biopsy or a double punch biopsy to go down into the subcutis, because the disease process is more in the subcutis. The overlying skin may just be normal. So you will, in paniculitis, you will have either septal inflammation or lobular inflammation. Lobules are these fat lobules, and then septi are these fibrous tissue that is kind of containing the fat lobules. This is a very nice diagram of basically giving you the concept of septal versus lobular paniculitis. In septa, the inflammation is more or less confined to the septum, and in lobular, you have inflammation within the lobule. And depending on that, your differential obviously is different. If you have septal paniculitis, your main differential diagnosis is erythema nodosum, as opposed to lobular paniculitis. You can have lupus profundus, you can have pancreatic paniculitis, you can have alpha-1 antitrypsin deficiency, or even subcutaneous fat necrosis of newborn. So I'm going to conclude this talk with basically some key home points. As I'm told, most of you are either in medical school or going into medical school or applying for residencies. If you end up, this applies to most of the medical fields. You have to have a logarithmic pattern, clinical or or pathology. Once you have a logarithm, you kind of narrow down your differential diagnosis, and then you go from there. You either rule in or rule out one differential at a time. And then in pathology, you will have a lot of, especially in skin pathology, you will have a lot of overlap between different entities. So it's very important to take the whole picture into consideration and not just what you see on the slide. And then you do have to be aware of a lot of differential diagnoses. If you just jump straight to the diagnosis, you may miss other differential diagnoses that might be clinically relevant. And I know as a medical student, all the things that I just described to you looked pink and purple to me, but trust me, the more you see, it all starts to make sense. And the more you see the physiological role of certain cells and organs, and then you compare that with the pathology, it all starts to come together. So it looks scary, but it's not as scary. So the more you see, it just starts to become easier and easier, just like any other thing in life. And I will give it back to you, Manahel. That will be the end of the talk.
Thank you so much for sharing your career journey, your mentorship and teaching, Dr. Mubasher. We'll now begin our Q&A session. My name is Amna, and I'm a pre-medical student at the University of Maryland. So our first question comes from Muhammad Ahsan Gill, who asks, we often use CVAT bodies and colloid bodies as interchangeable terms. Is there really any difference, like one seen in the dermis versus other in the epidermis?
No, they're the same thing. They're basically necrotic keratinocytes. They're dead keratinocytes, and all these names, CVAT bodies, keratinos, they're all the same.
Okay, thank you. This next question is from Dr. Suhaib Khalid, who asks, in LS, what do we mean by sclerosed papillary dermis? Is it just more collagen deposition?
Sorry, what was the question again?
The question is, in LS, what do we mean by sclerosed papillary dermis? Is it just more collagen deposition?
Yes, and you see basically fading out of any of the normal skin structures in the papillary dermis. Everything is kind of pushed down in lichen sclerosis, and you just see a pink deposition of collagen, and that's part of the disease process.
Got it, thank you. And Dr. Khalid also asks if you recommend inking the gross specimen even when it's an inflammatory disorder.
Well, I know a lot of practices, they just ink any. Well, the phrase goes, if you think, ink. So if you're even thinking that should I ink or not, you should ink. But when it comes to inflammatory disorders, I don't think that inking matters, because you're not trying to take out the neoplasm. It's the disease process, and you're trying to give a diagnosis for a disease. For example, if you receive a biopsy from a rash, you're only getting a small portion of that rash, and inking will not really make a difference to the overall picture. because you're giving a diagnosis and the disease will be treated as a whole in the body and not just that specimen. Yes, it becomes important to ink the neoplastic processes. And if you're thinking that should I ink or not, I would suggest just ink the specimen. It doesn't harm anything. But strictly speaking, for inflammatory derm, I don't think inking matters.
Got it. Thank you. Now we'll be going into asking you questions related to your career path and specialty. So what got you interested in pursuing the pathology specialty?
So very interesting question. As I mentioned at the start of the lecture, most of us are not really exposed to pathology during our medical education. Just because when you think of a physician, you think of all the white coats and, treating the patient and or doing a surgery on the patient. And because that's what we see in the medical rotations. My real first exposure was during the research year that I did before residency at NYU. And I was paired along with a gastroenterology, the pathologist who was with interest in gastropathology. And she basically let me shadow her, and she kind of mentored me, and I learned so many things about pathology and career in general from her that started to kind of expose me more towards pathology and developed my interest. And the more I learned about pathology, because as I said, you don't really know the day-to-day working of pathology until you actually go in a pathology department and spend some time there. The more I spent time, the more the field grew on me. And looking back, I think that was one of the best decisions that I made.
Got it. Thank you. And also, why did you choose to pursue a fellowship in DermPath?
There are multiple reasons. My own interest in dermatology, and then my mentors during training, Dr. Phelps, Dr. Singh, all these people during my rotation made me feel like I'm part of the team. And also you see their work ethic and you see their command of the field that really kind of their passion rubs off on you. So I would say that's one of the main reason, in addition to the fact that that's something that I really clicked, where you take the clinical into consideration. I mean, you do the same with the GI pathology and the other parts of pathology too. You have to take clinical entities into consideration. But with skin, it matters more that you're aware of those clinical entities, because there's so much overlap. So I think it was a number of factors that made me decide to go into dermatopathology.
Right. Yeah, I understand having a mentor is really important to be able to choose your career and go along your journey. So our next question, personally, one thing we are told in school is that pathologists and radiologists have limited interaction with patients, and if we prefer to work without them, to become a pathologist or a radiologist. So how much time do you personally spend with patients, or do you spend more time analyzing and diagnosing patient tissue in the lab?
Well, I spend more time or most of my time analyzing tissue in the lab. But one of the other aspects that I really liked about dermatopathology was that you as part of your training, you have to go to the clinic, you have to see the patients, and that's how you become good at the dermatological entities. So there is part of my job that deals with interacting with the patients, especially during the training. But when it comes to day-to-day working, most of my job is making the diagnosis and dealing with mostly other physicians, specifically surgeons or dermatologists or gastroenterologists, and like doing tumor boards, and also giving their diagnosis and discussing the clinical differential. So as such, if you do want to end up spending more time with the patient, that's the beauty of pathology. There are so many aspects of pathology where you can interact with the patient. For example, if you have apheresis, you interact with the patient because you're the one performing the apheresis. Or blood banking, you are more interactive with the patient. Or cytopathology, where you're performing FNAs on the patients and giving the stat diagnosis. So there are parts of pathology, if you're interested in those, and you want to keep the patient interaction part alive, I think there are parts, but yeah, for the most part, you don't deal with patients. You deal with they call pathologists the doctor's doctor. So basically, you deal with mostly physicians.
Got it. Thank you. Our next question is, what is your day-to-day schedule at work like?
So my day-to-day schedule mostly is interpreting the biopsies or excision specimens, or presenting on the tumor boards of the findings that we have in our pathology reports. But that can totally vary depending on the kind of practice you have. If you're in a more academic setting, and you have residents and medical students rotating with you, then you'll spend much more time teaching them or giving lectures, and less time on the diagnostic side. Again, if you're on the research tracks, then you spend more and more time playing with the tools that you have for research, and owning your passion in spending time with the research experiments. So it totally depends on what you want out of this field. Again, another beautiful aspect, it totally is very flexible of how you want to tailor it.
Got it. Thank you. Our next question. So some students were interested in possibly pursuing research opportunities in pathology to figure out if this is the right field for them to pursue. Can you tell us a little bit more about your research, and if you have any recommendations for anything else students should be doing to decide if pathology is the right fit for them?
I think that's very important. Any field that you want to spend the rest of your life in, because most of the people who graduate from the medical school are in their third decade of life or fourth decade of life, and they have like 2, 3, 4 decades of career in them. And it's very important that you make the right career choice, because people who are really passionate about what they do work becomes easy, work becomes your life. It's not really work. But if you don't really like that and you're just doing it just because it's work, it becomes hard and you have to really push yourself. So I think it's very important to spend some time in a pathology department and see for yourself, spend day in, day out with shadowing a pathologist, or I think that's the best approach, to shadow a pathologist, to see what their work-life balance is, and when they work, what satisfaction they get out of their work. So I think that's the best advice, to just go shadow a pathologist or do electives, do observerships. I mean, if you have research opportunities, that's obviously amazing. And you do need research because pathology is very research heavy. But I would say in-person electives trump over other aspects in deciding in deciding for you to select a career path.
Thank you so much for that advice. And finally, for our last question, how do you manage your work-life balance?
That's the best part about pathology. Even during training, you have mostly your weekends are off, unless you're on call. Same with the day-to-day life after the training. Your weekends are mostly off, and most of the calls are like CP calls. You can take them from home. For AP calls, you have to physically come to the hospital. And I think comparing my work-life balance with my colleagues in other subspecialties, I have nothing to complain about.
All right. Thank you very much, Dr. Mubasher. We really appreciate you taking the time to mentor us today. I'd love everyone to please give a warm thank you to Dr. Mubasher in the chat box for this incredibly informative session.
Thank you so much, and good luck to everyone, and whatever they're pursuing, good luck. Thank you.
Thank you, Dr. Mubasher. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. You will need a 70% or higher to pass and receive certification credit for the session. So you'll be emailed a certificate for attending. Actually, these dates are all posted, for our next session dates. They're all posted on our social media outlets as well. So please be sure to follow us at TeleShadowing. And if you want to receive notifications about these upcoming sessions, you can also register with your email on our website here, teleshadowing.com/join. So I highly recommend, if you're interested in these types of sessions, this month is pathology month, but every month we have a different specialty spotlight. So if you're interested in joining any of these sessions, feel free, and it's a free program. So these dates will also be posted on our social media outlets. So our next live session will be on Saturday, April 15th at 9 a.m. Eastern Standard Time with another physician mentoring us in pathology. Thank you so much, everyone, for attending today's session. It is actually our 100th teleshadowing live session, so we hope to see you in upcoming sessions as well. And this concludes this week's shadowing. Thank you.